Welcome back. This is not the beginning of the end, but it is perhaps the end of the beginning of the journey of this course. Treatment essentials. Today, we have already covered intervention types, primary, secondary, and tertiary, and covering any one treatment in depth would be outside the ken of this course, so we will lightly cover two things: mindful acceptance and behavioral change. And our roadmap will be the trans-theoretical model of behavioral change. This model is meant to be descriptive, so it contrasts with the Alcoholics Anonymous 12 steps model because the 12 steps of Alcoholics Anonymous are meant to be didactic, or the steps that one must take for recovery from addiction, while the trans-theoretical model acknowledges its steps. The steps of the trans-theoretical model are just typical stages we would expect to see in normal recovery processes. There are no requirements in the trans-theoretical model, like being of service to others, for example. The closest thing to a requirement in the trans-theoretical model would have to be that the person moves through the contemplation stage and becomes mindful of a problem, so they start to plan and address it. So that is where we will start. Without awareness, we cannot expect change. To change, it's generally required that one comes to several painful insights. These include insights regarding the problem, its consequences, the scope of the problem, one's past denial, which is a big thing to confront, and perhaps redundant at this point, the need for change. Mindful acceptance is the term for this initial cognitive change. Mindfulness is generally accepted to have two parts: awareness and acceptance. Let's get a small sample of mindfulness definitions to get us on the right track. Mindfulness is being aware of yourself, where you are, what you are doing, what you are thinking, and how you are feeling. Mindfulness is withholding judgment about our emotions, not being reflexively driven by them to think certain things or make certain associations. Mindfulness is a state of non-judgmental, sustained, and alert awareness. From quantitative studies, it seems that a key component of mindful acceptance is self-compassion. The more you endorse the following items, the higher you will rate yourself on self-compassion. Is this true of you, and to what extent? When things are going badly for me, I see the difficulties as part of life that everyone goes through. When I'm down and out, I remind myself that there are lots of other people in the world feeling like I am. I try to see my failings as part of the human condition. When I fail at something important to me, I try to keep things in perspective. I'm kind to myself when I'm experiencing suffering. And finally, when I'm feeling down, I try to approach my feelings with curiosity and openness. We tend to confuse acceptance with agreement or endorsement. We have difficulty accepting things we do not like, for example, our failures, limitations, responsibility for them, and have an irrational idea that accepting such things, acknowledging they exist, is somehow akin to approving of them or conceding defeat. Accepting that a problem exists is not supporting its existence, it's simply acknowledging it. For example, we can accept that someone we love holds foolish beliefs without agreeing with them, but even this can seem hard. Imagine how much more difficult it is to see and acknowledge and accept facts, behaviors, and aspects pertaining to ourselves that we do not like. Acknowledging these things is not giving up or giving in to them. It's the first step toward change. In the addictions literature, mindful acceptance of a problem is the first and necessary step to change. By some models, this comes after denial and anger stages, and by some, it comes after pre-contemplation. Onset of mindful acceptance may be gradual, perhaps as the client is talked into addressing an issue by loved ones, or mindful acceptance may come suddenly, such as when a friend dies of overdose or when one fails out of a program. A term for this sudden mindful acceptance is quantum change. Selected here are 8 typical types of resistance to mindful acceptance. For each, I will give you the gist, an example, and a counseling tip that may or may not be useful for any given case. Denial is the most common type of resistance to mindful acceptance. Here the issue is the lack of acknowledgement of an issue, and what we want to do is compassionately look for good reasons why the client would present with denial. While we're looking for these good reasons, we need to remind ourselves not to use them as a weapon or an argument against the client. Don't accuse the client of defensiveness or denial, because we all know where that will lead. But as we've been emphasizing with the evolutionary approaches and the psychodynamic approaches, look for good reasons, so these can be addressed and accepted. The minimization defense mechanism, describing or framing the problem as smaller than it is generally used to maintain the self-esteem of the individual. We've seen this before. My behavior never hurt my children. I only drank outside the house. My job is fine. The source looping universal premise being, when the problem is this size or has this particular aspect, it is not sufficient or real enough to be addressed. The counseling tip here would be to bring in either their own words from motivational interviewing earlier, or some kind of outside help that says, no, you really do have a problem and we support you in finding it. The counseling advice is not to get into debate about the universal premise being put forward. It is true that if you are an addict and your job is not suffering, that is a good thing. Don't let the client rope you into saying something absurd or even argumentative. Just present the world so that they can start to see it and move toward acceptance of what you present. Next, projection. Thank you, Freud. This is seeing the conflict that you have as a conflict in other people. Someone angry with themselves about their substance use may say that their family members are angry at them. And in the psychodynamic model, this projection is protecting them from acknowledging that they have these anger feelings. A nice deep example would be the client says, you think I don't care about providing for my family. Well, I don't think it takes 9 years of education, an MD and a PhD, to see that this person is concerned that their behavior implies that they don't care about providing for their family. The client may here be leaking his actual concern about his ability to provide for his family. Since these are generally deep and important waters, and projection manages to get us on the right theme rather quickly, be sensitive and cautious so that this space can be revisited. Don't poison the well here when you encounter projection. And maybe use distancing language, like, well, I could see how somebody might think that you don't care about providing for your family. I think it's clear that you want to provide for your family, but I could see how somebody might interpret your behavior as implying otherwise. And if you look at the actual objective face of what we're doing, we're just trying to describe things as accurately as possible. Next, the one we were obliquely dealing with, or at least dealing with most in the alcohol lecture, rationalization, or cleverness used to avoid responsibility and feelings. Drinking, for example, is a short-term anxiolytic. It will make you feel a little better in the short term. So when somebody says that drinking is a natural result of workplace stress, they're not wrong. Their argument just probably isn't as good as they think it is when placed in a larger context. The counseling advice here is generally just not to show weakness at this point. It can be frustrating to deal with a rationalizing client, or yourself when you're rationalizing. Next, and perhaps counterintuitively, we have compliance. Compliance is a problem? Yes, when it's hollow agreement, agreeing with everything. Maybe just to dodge criticism, or maybe just out of rose-colored over-optimism. Yes, all these things you were saying, they're perfect. I'm gonna do all of them. Thank you, you're amazing. That was a little bit too easy. Let's make sure you're actively engaging in these things, setting realistic goals, keep things measurable, and encourage some back and forth. Things should, after all, be individualized. Related here is conflict avoidance. This is a separate construct to remind ourselves that agreeing in order to avoid conflict is not mindful acceptance. This is a check to see whether the client is actually believing what they're saying, and to look for related beliefs, like the idea that they're okay with the risks of the addictive behavior, even though they believe or say they believe that the behavior is a problem. We want to make sure there's actual awareness here. Again, related to compliance compliance, we have obsessive focusing. Here we might have a client that is intensely critical of herself in one capacity or in one aspect and is focusing on that at the expense of pursuing other important aspects. She may be right that since it is the stress of job hunting that is precipitating much of the addictive behavior, settling the job problem will make it easy to settle the addictive problem, but it may be your job as a professional to widen the purview here or diversify the areas of time and emotional investment to better assure a positive outcome. That said, obsessive focusing is not limited to the compliance realm. You could have someone who wants to spend all of the available time essentially deflecting onto some secondary issue, like the fact that they're only there to make one of their loved ones happy, and let's talk about what's wrong with that loved one and why they're against me and why they think I need help with my quote-unquote problem. Obsessive focusing can choose anything as its target. We want to validate concerns wherever we can, but zoom out and get realistic interpretations of what is relevant at the forefront of conversation and attention. Next, we have acting out. Whether the client arguing with you shows that they have a lack of awareness of their feelings or not, it's a tough thing to encounter. If instead of responding to your deep and probing Freudian question, the client say, I could do your job. How do you feel? I could do your job. Or says something they think you'll disagree with and then asks you, does that bother you? The trick here is to harness that aggression and just point it in the right direction. Look, I like that you want to punch me in the face right now. I just want to replace my face with whatever your actual problem is. But protect yourself. There are huge individual differences in what people do when they are provoked or feeling cornered or uncomfortable or experiencing emotions. So make sure the client is not between you and the door to the room. Just in case. So far, we are spinning our wheels and not getting anywhere. We need some motivation tricks. How do we get people moving? 8 suggestions follow, and when using any of these 8 suggestions, always understand the client's perspective. The aim is to address the client's belief systems, thoughts, and attitudes, trigger mindful acceptance, and motivate behavioral change. First, giving advice. If you can, and when they will hear it, specify the problem. If that is acknowledged, justify change. Advocate for whatever specific change you advise. This advice, like leadership more generally, should be presented with confidence and the courage of your convictions. The advice, as much as possible, should be framed in the terms that the client uses themselves to describe the problem and the situation. And as much as possible, it should sound like they are telling themselves that you are stitching together a bunch of things that they are trying to tell their self. Suggestion 2, remove barriers. First, you'll need to specify the change blockers. Put that in quotes, change blockers, and then work to address them. Use second-order thinking here, thinking about thinking, to address deeper resistances, since much of what is in our way is also in our heads. Not necessarily just in our heads, but in our heads. Third, provide choices. Specify a few options for behaviors, treatment, or other ways to address the issue. Discuss these options, weighing them with the client. Let the client choose. This choice supports intrinsic motivation and is related to success in therapy. Fourth, decrease the desirability of the unwanted behavior. A common cognitive behavioral therapy approach is to specify the pros and cons of quitting. In the process, we can gain motivators in the form of the cons for continuing and pros for change. And we also have the opportunity to reframe as negative or less desirable the pros of behavior and the cons of change. Get the client to tell you the costs and remind the client of these costs. Fifth, practice behavioral empathy. Even if it is the 10th time you've had the same circular conversation with them, they still need to be heard and seen. Accept the client's emotions, reflect feelings and emotions back to them. This is important to you, I see that. And normalize their internal conflict and ambivalence. It is natural to have arguments with ourselves, even where there is a preponderance of evidence or strength on one side of that argument. Sixth, provide feedback, especially the kind that reflects back to them what they have said. Respond to specific points that they have made. Acknowledge the content and the behavior of the discussion that you have had with them. Feedback what they've said and how they've said it. And when you do, it may be the first time that they actually hear or perceive it. 7, help them with clarifying goals. Identify the goals of the client and make them as specific as possible and as attainable and realistic as possible. There's a lot of resistance to making our goals specific enough that we would know when we fail. That's a big part of your job as someone helping someone else through addictions or as someone helping yourself through behavioral change. Finally, make the effort to engage actively. Express your interest in the client's change. Demonstrate that interest in the client's change and the client as a person. One thing you are likely to see in offices of seasoned professionals is notes about the individual client's personal life. These are non-essential specifics that you could inquire about, inroads to opening a deeper dialogue or connection. You might see a note on the administrative assistant's desk, like the client has a dog named Lasso. Then you'll hear the seasoned professional ask, does Lasso still expect you to go for smoke walks now that you've cut back on your smoking? Small touches like this go a long way to show that you care or are invested or are at least paying attention to the smaller things that the client says. This human element is important, and even when we know that it's just a clever trick, these things still work. We like when people pay attention to us. Now let's say the client is motivated and assured that an attempt is worth the effort. How do we prepare for change? A behavioral analysis. Get some data. Just like you don't make a budget based on your aspirations, since we would all aspire to have zero expenses, but that's not going to happen. Just like a budget, you start with an honest assessment of what you are starting with. In the case of a budget, what do you actually spend now? In the case of a behavioral analysis, what do you actually do now? And set your goals to be gradual steps away from where you are toward where you would realistically like to get. These gradual steps are called shaping of behavior. Recall the power of reinforcement. It's what got us into this mess of addiction to begin with, and it's what's going to get us out. With punishment, we have an attribution problem. If I am being punished, is it because of what I have done? Is it that what I have done is bad? Or am I being punished because I am bad? If we attribute the punishment to our being bad, we may just lean into that role or attribute and end up further into the styles and habits we once thought did not represent us or our best interests. With reinforcement, we do not have that attributional problem. Whether we attribute a reward to the behavior being good or our being good, it is progress in either case. Also, recall from intro that we do not want to reward every desired behavior. That's not a reinforcement schedule that would work, because we want the behavior to persist in the absence of our reinforcing it. We do not want to squash intrinsic motivation. We want to build it by fading out external rewards for desired behavior. The relevant Skinner quote here is that the human organism is rewarded simply by being effective. The more that effective behavior gets enacted, the less the client needs any reinforcement scaffolding from us. With an applied behavioral analysis, our first step is do nothing, but track what is done. This gets us a baseline of behavior. Once we have that, we can calibrate reasonable small goals, short, medium, and longer-term goals. Behavioral therapy may not be as glamorous or as in with the cool kids as cognitive behavioral therapy, CBT, but nearly all of what CBT can do can be done just by BT. One of the most recalcitrant and difficult substance use disorders in existence is cocaine use disorder. Behavioral therapies are the only well-established, i.e. proven method for treating cocaine use disorder. We do not have any well-established pharmacological interventions. We need to get into the environment and manage behavioral contingencies, preferably by tasking the client's significant other or someone close with monitoring and reinforcement, something called behavioral couple therapy, which is powerful, but it risks offloading responsibility onto that significant other. We could also turn the nuclear Skinnerian key to unleash the most powerful reward system of operant conditioning, variable ratio rewards. Competing with the reinforcing power of something like cocaine is nearly impossible, but lotteries seem up to the task. These could be actual lottery tickets, or more commonly, something like clean drug tests get clients tickets for some other sizable reward. Common examples include gym memberships and gift cards, maybe a donated new car. Where these rewards are in place, we get clean drug tests, far more clean drug tests, and far longer subsequent abstinence than any other method, pharmacological, psychological, or judicial. Behaviorism is as powerful as cocaine, and we do not have to pretend in behaviorism that we can measure and change thoughts and emotions. We only have to measure observables. Attend to reality. Since alcohol use disorder would be the common thing that we encounter, let's zoom in on behavioral therapy for alcohol use. We get our baseline and we get some short, medium, and long-term goals. We look specifically at contingencies that are likely to cause problems. These are called known antecedents or triggers. We set the individual up with a means for self-monitoring so they can be rewarded simply by being effective, and so that success, however small, is made eternal by recording it. We can always go back and look at whatever success we have had. And we give clients things to do. These things that we have them do can be turned into habits. Here is a self-monitoring tool, a transdermal sensor that tracks blood alcohol levels. Whether you are taking a rational recovery approach and therefore have an allowed level of alcohol in your system, or are looking to prove that you are wholly abstinent, this serves to monitor and evidence your progress toward your goal. There are also, of course, breath tests for alcohol. These technologies are generally referred to in client charts under contingency management plans or devices. Since the reward of success may not be enough on its own, you will need to find for the given client their competitive reinforcer, i.e. the thing that could possibly provide a reward that would compete with the reward or the relief of the addictive behavior. Some generally good ones include lottery tickets, which are inexpensive for you but have a rewarding response that is quite disproportional to this small cost. Money vouchers, sometimes contributed by corporate partners who want to do good at minimal cost to themselves, such as tickets to a show, gym memberships, dinners out. Chip here is another word for token, the idea being that you can get a voucher once you have a certain number of chips or tokens, and be creative here. Anything of benefit to the client should earn them chips. Job hunting, exercising, engaging in their hobbies. Another competitive reinforcer, though dose response curves may vary, is physical change. Cardiovascular exercise is the best way to get high on one's own supply, and it yields remarkable results in terms of improved mood, cognition, and being a stimulus substitute that is not some other random substance of abuse or terrible habit that you swap in. This has to be individualized. Cardio is any sustained physical activity that is difficult for you to talk through because it requires paced breathing. If that is simply walking around the block, then that is your cardio. But do it enough and you'll have to upgrade because walking around the block will no longer be a challenge for you. Our external reinforcers should be utilized early in the plan, and this is where they can do the most good, establishing initial adherence to the plan. They should be customized to the given client and the therapeutic community that we may be having them engage in. An overview of the behavioral planning stage might go like this: a motivational interview where we find out the problem and specify what are called motivation establishing operations. Why are you here? You would like to have a child in the next few years and want to make sure your substance abuse is long gone before then. Okay, that is what we will turn to whenever we need to. We may even put that sentence on a cue card that the client can carry in her pocket. Be healthy for baby. Maybe the client places a picture of herself as a baby in her bathroom mirror to remind herself of this motivation. The motivational interview finds and formalizes these motivations and gives us something to work with. Next comes a functional analysis. What are the antecedents and consequence of the behavior to be changed? What typically comes before it and what typically comes after it? If you have perused the self-help section of the bookstore and opened up a few addictions self-help books, you have seen blank tables to aid you in your recovery. This is generally where the PhD who wrote the book tells you to put your behavior, what prompted it, and what resulted from it. Excel is a powerful ally in behavioral change. Next, we change our antecedents wherever we can, but where we cannot change certain triggers or stressors or prompts to turn to the addictive behavior, we can practice coping with them. Popular elements here include strategies of relaxation, refusal, self-assertion, redirection, and distraction. Penultimately, we can contract our contingencies, what we will do, how things will be measured, the situations we will avoid, like neighborhoods, cookie aisles, apps, or friends who use, and the behaviors or coping we will engage in when things get difficult. Finally, we prepare for failure, which is inevitable and temporary. This could be folded into contingency contracting, but it must be explicitly addressed. Addictions are chronically relapsing disorders. To not prepare for relapse is malpractice. A follow-up period of 6 months to a year after successful treatment is the bare minimum. Much like treatment should be individualized, it must prepare for and make itself available for the event of relapse. Okay, Professor, but if you're so smart, then why am I still addicted to things? I've taken this entire course and it hasn't helped me. Well, I can take one more crack at checking the insight box, but I can't move your body for you. Your homework is to determine your typical procrastination style. Which type of procrastinator are you? The perfectionist, the dreamer, the worrier, the defier, the crisis maker, or maybe the overdoer? The perfectionist waits for the perfect situation to act and thus misses their opportunity to grow. Maybe you will change once your job is sorted out, or maybe there will be something else that makes the situation not quite perfect for change. There's no time like the present. Next, the dreamer. Do you have very confident but very unrealistic goals? Are you all talk? Do you say things like, well, one day I'm going to do this, or I'm planning to do this? Let me see your steps and how many of them you've taken. Aspirations are cute until you're an adult, and then you're going to want something a little more specific. The worrier procrastinator is very good at raising reasons, not for taking action. Well, I can't risk changing my focus off of this one thing. I'm spinning this one plate on a stick over here, and if I stop doing that, then the world will end. I gotta spin this plate. Or what if I attempt to change my behavior and it affects my work performance? There will always be things to worry about. And one of the accepted good practices in dealing with anxiety is to follow the anxiety spirals down to the worst possible outcomes and then say, okay, so what? So that happens. At some point, you're going to have to put all the worries together and make a decision based on realistic weightings of the worry. So I'm going to sit here at the end of the worry road and wait for you to get to me after you've done your circuitous path. And when you're ready, we'll address what the real problem is. Are you the defier? Then you're kind of my kind of person. But doing what you want will probably result in continuation of the same behavior. So no pressure, but I encourage you to express what it is that you actually want and take as realistic steps as you can to that. I don't want to tell you what to do. I want to help you follow what you know you need to do. Or what you will know you need to do if you just take some time to observe yourself and figure it out. Or are you the crisis maker? Are you good at conjuring drama to distract away from what needs to be done? Do you say things like, you don't have the emotional headspace to deal with this right now? Well, the this that you don't want to deal with is the thing that is shrinking your available emotional headspace. So let's try to find the foundational problems. We'll call those our crises and work on the others in turn. Finally, do you procrastinate by overdoing the one thing that you are capable of doing? For my health goals, I want to be healthier, so I'm going to work my way up to jogging 5 kilometers twice a week, eating healthy, and drinking lots of water. I've been focusing mostly on the drinking lots of water. I've gotten myself up to 20 cups per day. I'm doing really well with the water thing. I'm making great strides toward my goal of being healthier. Yep, you're doing great with the water. Let's transfer some of that energy into something else. Which is your typical procrastination style? Describe in as much detail as you can an occasion where you displayed this style. This is to help you understand yourself. You may notice that it's difficult to write this out. You want to rationalize your procrastination. You don't want to objectively describe it. People procrastinate in different ways and are not limited to just one style of procrastinating, and they do so for different reasons, all of which are great reasons. There are great, perfect, wonderful reasons to procrastinate, but your well-being is even greater than those great reasons, and you know it. The challenge is to motivate change and structurally disincentivize procrastination. You can do it. I believe in you. Bye-bye.
In the time it takes to wonder you're still here. It's over. Go home.